other thing is you just mentioned the blood pressure. So let's talk about that. That's the other reason why I start sedation right at the very beginning, because I want to get an idea of where we're starting with the blood pressure. So they get them all hooked up, right? They get them hooked up and they're on the table, they're prone, and already their blood pressure's up because they're nervous.
Right.
And so I just say, time out. Okay, what's our starting blood pressure? Typically it's like 180 over 95, or, somewhere in that range of 160 to 200 sometimes. And so it's like, okay, let's start 150, or if they're a big person, I'll start 250 even. And then, recheck their blood pressure, and then we'll scan them because I don't want to, if I don't see any drop in blood pressure, then I start with and they even look a little bit sleepy. Then I'm like, okay, let's start with a dose of hydralazine. Let's see where that takes them. And if after after sedation and a couple doses of hydralazine, they're not under 160 or even under 155, then I'm like, let's call the nephrologist, send them back up. They got to get their blood pressure under control, and we'll try again tomorrow. Because to me, that's where you get the bleeds, is that uncontrolled blood pressure, even after sedation and multiple attempts at control with hydralazine and or labetalol. But tell me what your process is with blood pressure.
So, kind of like you mentioned, I always want to know about the blood pressure, even what's their baseline when they come in, when they're just kind of when we first get them in the pre-op area. So I want to know what a baseline blood pressure is. And so I have an idea whether or not we're going to need to do blood pressure control. Sometimes I'll give clonidine pre-op, 0.1, 0.2, or 0.3, depending on the blood pressure. And when they're in the procedure, like you said, get them prone. And sometimes for whatever reason, for a couple of reasons, the blood pressure oftentimes goes up, 5 or 10 points, when they're prone. And then when we're doing the timeout, get them sedated, you'll get a drop in blood pressure then. And then this is kind of your new area to work. So my target is under 140. That's what I'm looking to go for. I will biopsy, depending on the situation, between 140 and 150. But I really, really like to get it below 140. For the longest time, I was doing under 150. And then at some point I did a lit review and I found that a systolic below 140, diastolics below 90 is kind of what the target is. But because for so long I was doing them in between 140 and 150, I'm more likely to flex on that. Mm-hmm. But I will not biopsy if it's above 150, or at least without a strong conversation with nephrology and whatever. In a lot of scenarios, that would be an inpatient about how necessary this was. But yeah, after I know that their blood pressure is, I know my target, and then I'm giving doses of hydralazine and labetalol, sometimes in tandem, 10 and 20 or 10 and 10, 20 and 20, depending on how high their blood pressure is. And as soon as I get below, then oftentimes if I know if I'm within striking distance, I'm getting that needle position to take the sample. But if it's we're starting out at 220 or something like that, and I'm still trying to get it down, I'm probably not even going to start the case until I've gotten the blood pressure within very close range of what I think our target is. But this is one thing where I think most people will differ, is what their target is, and then how likely they are to flex on it, and how much are you really helping if you bring them down from 220 to 130, you get your biopsy, and then 30 minutes later, they're tacking along at 220 again, right? I think you want to be able to, I think the safer move, the more and more, I look at our patients, we've had bad outcomes, it's when the blood pressure is through the roof, and we control it for the procedure, and then in post, they go back up they go right back up.
Yeah, for sure. And I'm the same as you. When I bring it down with that initial sedation, what I'm looking to see is just a drop, right? Because if they're not dropping with what you're giving them,
right,
then it's okay, send them up. They got work to do upstairs, right, on this blood pressure. But if you see a drop and your drop, it's trending down, and so you're at say you give them 2 and 50, 2 milligrams of Versed, 50 of fentanyl, and then you gave them maybe even 10 of hydralazine, and you're down in that 150-ish area. It's okay, let's go ahead and scan. Let's go ahead and mark our spot. Let's go ahead and start getting stuff. In the meantime, we'll keep trending the blood pressure. And if it shoots right back up again, then it's like, okay, that's a red flag before I've even stuck, right? If it's stabilized, then it's like, okay, let's try another round of hydralazine, or let's try, if they're still kind of awake, let's try another round of sedation. And then, like you said, I really like it. My number's 145. And I tell every nurse that at the very beginning, let's get them down below 145 systolic. And as long as we're seeing that consistently, then it's like, okay, then I don't work like rushed, but I'm working at a pace that, like, especially if their blood pressure start out really high, where I'm like, I want to get this done fast so that we can, if their blood pressure does shoot back up, like, we can control it, right? We're not like lollygagging or anything like that. So anyway, what I think we did a number on the blood pressure.
I will say that, like, yeah, we did do a number, but it's an important point. I think it's actually one of the cornerstones of a nice, safe procedure. Totally. But on the other hand, like, oftentimes there's a reason that the blood pressure is really hard to control. And that's also, like, kind of dovetails with the reason you might be doing a renal biopsy.
Right.
And so I get it. I think there's probably some people who are like, oh, yeah, I do them under 170 and it's safe. And, like, they do these measures. I think that's totally reasonable also. Like, I mean, I think that, like, I'm not saying that an IR doc is unsafe to do a biopsy with, like, an uncontrolled blood pressure, or not to say uncontrolled blood pressure, but a blood pressure that's out of that range that we talked about, because sometimes that can be one of the exact reasons that you're doing the biopsy in the first place. I think it's good to make every good faith effort to, like, lower that blood pressure and try and do it safely. But sometimes you also worry about tanking their blood pressure.
Yeah.
And so, like, it's a balancing act. Like, you don't want to tank someone's blood pressure with all the anesthesia that you're giving them and all the antihypertensives. But on the other end, you're like, if I have, like, a slightly higher blood pressure, like, in the end, I know I can, even if, like, I have a complication from the procedure, it's like on the back end, I know I can control that too, even though it may be, an angio and an embolization. But you do have that in your back pocket. That's still a minimally invasive procedure to go in and, take out a very small piece of kidney and then try and use a minimal amount of contrast. So I just don't want to come down, like, too much of a hard liner on this blood pressure thing. Because I think, like, every patient requires, like, either, like, some individual consideration, right?